Good morning, and thank you for this opportunity to add to the conversation that addresses how nursing can advance health equity. Do you believe that everyone should have the right to achieve their highest level of health? Well, every day, that fundamental right is denied to more than a few. In the 1980s, my grandfather told me that doctors didn't treat him as well as they treated people who were white. I tried to assuage his fears by telling him that things were different now. Healthcare was better. 20 years later, after he died, the Institute of Medicine's Sentinel document, Unequal Treatment, legitimized my grandfather's fears and exposed a painful truth about the healthcare system. The report amplified that when racial and ethnic minorities enter the clinical arena, they were less likely to receive routine medical procedures or essential clinical services. I was wrong. The committee made recommendations, and I, like many of you, we addressed our stereotypes, participated in implicit bias training, and tried to be more culturally competent. Yet the Agency for Healthcare Research and Quality has reminded us annually that disparities persist. They have even highlighted states with worse racial and ethnic disparities. Some believe that technology could help improve health equity. We have apps to help us manage our patient's condition, to inform patients whether their symptoms warrant a trip to the emergency room, and for patients to even confirm appointments and view test results. But to what extent does technology advance health equity? Recently, a colleague shared that when a patient who spoke limited English went to visit her doctor, she was told that her appointment was canceled because when she was contacted by phone and text, she failed to confirm her appointment. The patient responded in Spanish that she didn't understand the message. Nevertheless, she was still sent home. Besides apps, Dr. Eubank, author of Automating Inequality, How High-Tech Tools Profile, Police, and Punish the Poor, shares a different view on technology. She says that we are living in an age where algorithms are being used to rank individuals and determine which struggling families will receive support. When computers rank families by who is neediest, resources are denied and families informed that they are not homeless or poor enough. While technology does have its benefits, we must never become enamored by the bells and whistles without fully considering what is at stake. Remember, algorithms are sometimes proprietary and they lack transparency. Nursing will have to become more tech literate, myself included. This was a challenge too. Ask critical questions and consider how high-tech tools could amplify existing inequities, harming the vulnerable populations we seek to help. The nursing profession, we are rooted in social justice. However, we live in a socially unjust world. Nurses see firsthand what health inequities look like, and it leaves many of us incredibly dejected and frustrated. I use the story of Lisa Gomez to illustrate this point. Lisa is a 6-year-old girl who has asthma, and she is one of 6 million kids in the United States who live in abject poverty. In 5 weeks, Lisa has 3 asthmatic attacks, and each episode results in her being treated in the emergency room, only to be discharged back to the same conditions that contributed to her asthma. Sadly, during the 4th attack, Lisa has a prolonged period of anoxia, and she dies. What happened? Sometimes nurses are led to believe that educating families like Lisa's will help individuals make wiser choices regarding their health. Well, without further context, some are conditioned to believe that poor health outcomes are largely influenced by the choices people in poverty make. The 2018 county health rankings counter that myopic view, and they remind us that individual behaviors contribute only a small part of health outcomes. Did you know that Lisa's physical environment, socioeconomic factors, and limited access to high-quality care played an even greater role in her demise? Indeed, social determinants of health are critical drivers of health. For Lisa Gomez, her mother's low income did not provide her with an opportunity to choose a neighborhood like many of us might reside in. Lisa lived in an area of New York that has the worst air quality in the state and is referred to as Asthma Alley. Why are places like Asthma Alley allowed to exist, and who is likely to live there? We can safely assume that Lisa's mother did not choose to live where the air quality is poor, just like none of the families in Flint, Michigan would have sought to live where their water would be contaminated. But for so many, low income levels eliminate housing choices, perpetuate racial segregation, and discriminately force those who are socially disadvantaged to choose between living in an unhealthy area or a toxic area. In 1965, Jack Geiger, the father of community health centers, amplified the futility of treating individuals who were sickened from contaminated water and then sending them back home to drink from the same well that caused their illness. Yet in 2019, Lisa's story reminds us that the price of health equity has become a luxury that many just cannot afford. Our failure to discuss racism as a determinant of health dismisses the realities of what living in America while poor and disenfranchised are really like. To be clear, low income and racial discrimination relegate some like Lisa to zip codes where their life expectancy is shorter, high school graduation rates are lower, and their opportunities for change are significantly limited. So where do we go from here? To start, Pamela Cipriano, the past president of the ANA, she urged us to confront racism in healthcare. Articles like Dr. Hall's echo that eliminating health disparities will require us to discuss racism. My colleague, Dr. Julian, and I urged our nursing colleagues to have an open discourse about race and racism, because even in nursing, the color of your skin still matters. Researchers from UCLA opined that poor health is probably more affected by structural racism than individual phenomenon. So they called for more studies. 6 years later, researchers from the University of Virginia and Michigan directed our attention to the growing body of research that points to structural racism as a driver of racial health inequities. But who is facilitating this discourse in our classrooms? Dr. Mary Bassett, New York City's past health commissioner, posited that although we want to better understand how social factors drive inequities, many, and I quote, academics, policymakers, and scientists are hesitant to identify structural racism as a root cause of inequities. Her team defined structural racism as the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems of education, housing, health, and employment. These patterns and practices, in turn, reinforce discriminatory beliefs, values, and the distribution of resources, which collectively contributes to adverse health outcomes. So how could structural racism result in Lisa being placed in Asthma Alley and contribute to her death? Through inequitable systems like housing and health that are coupled with the racially discriminatory ways that resources for low-income families are distributed. I know it's complicated. It happens every day. Case studies like this one, published in the New England Journal of Medicine, serve as an episodic reminder that inequities persist. Discrimination is real, so we must not be afraid to discuss it in our classrooms or in the boardroom. Ignoring structural racism won't make it disappear. Discrimination is here. Icebergs have been used to metaphorically illustrate that when we, like the Titanic, fail to acknowledge the structures that are hidden in plain sight, health is jeopardized, and more leasers are likely to die. We must not be comforted by our ability to address downstream factors, for history has shown us that no sooner than we address the needs of one, another person floats down that toxic stream, and we are left frustrated, and the cycle continues. My colleagues, I know you are empathic. How do we vertically advance health equity and build a better America? I implore the Future of Nursing 2020 to 30 committee to look upstream and ensure that nurses understand, recognize, call out, and are empowered to mitigate structural racism, the invisible forces that have infiltrated our society and our healthcare system. The Future of Nursing must turn the profession's attention to structural racism as a root cause of health inequities. We must argue against a curriculum that does not adequately address racism or contextualize race. When I ask why Lisa Gomez died, I shouldn't only hear that she probably didn't know which metered dose inhaler was her rescue inhaler. We must consider the extent to which structural racism played a role. While racism is a difficult topic and could evoke a lot of angst, we must collectively rise above any level of discomfort and remember who we are. Compassionate nurses, voted time and time again the most trusted profession. So I trust the Future of Nursing will be a game changer, and not just for the healthcare system, but for society at large. None of us would move into a condemned building if only one room could be restored. Likewise, we must not be content with restructuring healthcare while ignoring the other discriminatory systems that impact health: housing, education, and employment, and the criminal justice system. We can no longer afford to meet patients at their socially constructed level of need. We must partner with other disciplines and create the policies and practices that will extinguish structural racism and allow the promise of health equity to be fulfilled. In closing, while technology is attractive, it is not a panacea, nor is it a magic wand that can make structural racism disappear. Humans created it, and only we can destroy it. The path to social justice will require courageous conversations that embolden us to extinguish century-old discriminatory practices. We must not forget, as Dr. Beverly Malone says, we need daring ingenuity. I know this is a tall order, but the students we graduate today must have the capacity to ensure that Lisas of tomorrow can truly achieve their highest level of health. I know we can do it, and I know this information does not cause people to get excited and celebrate, but I know in 10 years I'll be back, and we will celebrate, and I'll let my grandfather know healthcare is better. Thank you.
Good morning. Thank you. Thank you. Molly is going to be our third panelist. Molly, do you want to be here, or are you going to?
I'm going to go up there.
Come on. Okay, great.